Mr. Chairman, ladies and gentlemen, dear colleagues, I would like to thank the organizers for giving me the opportunity to talk to you today about gynecological sarcomas. I would also like to acknowledge my co-workers in creating the Danish guideline on treatment of uterine sarcomas, and Professor Claus Høgdahl, who is the chairman of the Danish Gynecological Cancer Database. This is my agenda. Gynecological sarcomas are rare tumors. We only have around 30 gynecological sarcomas in Denmark per year, in a country of approximately 6 million people. That means that the 1 out of 100,000 women will have a gynecological sarcoma. Put on top of that, at least 15 different sarcomas are found in the uterus. Fortunately, half of them at least are leiomyosarcoma, so that gives us something to work with. We have around 15 per year. I've highlighted in this slide the sarcomas that I'm going to talk about, but I'd like just to point you briefly to the attention to the rhabdomyosarcoma of embryonic type, because that one needs chemotherapy prior to surgery. I would also like to mention the synovial cell sarcoma, because that one gives lymphatic metastases, whereas most of the other sarcomas will spread by the hematogenous way. And then finally, carcinosarcomas are not categorized as sarcomas, they are categorized as carcinomas. This is the stages, and in stage 1, the sarcoma is limited to the uterus. And that's important to know, because only in stage 1 we can hope for cure. The rest of the stages we may postpone death. In stage 2, the tumor extends beyond the uterus to the pelvis. In stage 3, it extends into the abdominal tissues, and in stage 4, it invades the bladder or the rectum or gives distant metastases. This is a Norwegian study, over 30 years actually, enclosing 419 patients, and as you can see, the average median age for endometrial stromal sarcoma is the early 50s, and for leiomyosarcoma, the late 50s. But there's a very wide age range from 20 to 30 years and all the way into the old age. Our own data for the first 10 years in the database are in accordance with this. Actually, we found 74 out of 303 sarcomas in women in their 50s, and that is approximately 25% arising during this age. However, we also found sarcomas in women in their 30s and women more than 80 years old. We found approximately half of the sarcomas in stage 1. Now, how do we find them? Because they're so rare. The fact is that approximately 80% of endometrial stromal sarcomas present by bleeding. But now, if you remember, they are in their early 50s, most of them, and that is the time of the menopause, and virtually all women go through a stage of dysfunctional bleeding during menopause. Approximately 60% of leiomyosarcomas also present themselves by dysfunctional bleeding. And here it's important always to be aware that fibroids don't grow after menopause unless you are taking estrogen replacement therapy. And that means so-called fibroids that grow after menopause have to raise your suspicion of having to do with a sarcoma. The same is true for postmenopausal bleeding once examination. Now, you can't present to a gynecologist without being submitted to ultrasound evaluation. And it's important to see that if you have a fibroid, the vessels will normally present around the tumor. You will also normally have a tumor that's pretty well demarcated, but the problem is if you have a fibroid with necrosis, that will be difficult to separate from the sarcomas. The endometrial sarcomas normally have a lot of little, outwards, a lot of little vessels inside the tumor, and it may be difficult to see where does it end and where does the myometrium start. This is also an endometrial stromal sarcoma, and this is a leiomyosarcoma with areas with vessels. The leiomyosarcoma often have necrotic areas too, whereas the normal fibroma will often have acoustic shadows and sometimes calcifications. The CT scan is not very good discriminating between sarcomas and fibroids. So the right here, we have a benign fibroid even with calcifications, and you can easily discriminate the bladder from the tumor, and you can also follow the gut here, whereas in this one, you can't see where the tumor ends and where the pelvic floor starts. So this is a sarcoma, and that is beyond stage 1. But if you look at it just like this, I'm not able to tell you the difference. So then what about PET-CT? Well, the problem with PET-CT is that some fibroids are still PET positive, and endometrial stromal sarcomas are rarely PET positive because of the very low mitotic activity. So PET-CT is very good if you know you have to do with a high-grade sarcoma. And this one is the same patient all the way through. And you will see the PET-CT is also very good to find distant metastases. But that's why we mainly use PET-CT when we know already that we have to do with a sarcoma of high grade. PET-CT also has a great sensitivity for evaluation of recurrent uterine sarcomas. But unfortunately, when using PET-CT, you submit the patient to quite a bit of radiation, so we don't use it for screening. MRI is possibly the best way to discriminate between sarcomas and benign fibroids. But you have to have an expert radiologist, and again, it's an expensive way to do it. This is from a published paper, and here you have a sarcoma in the bottom and a fibroid on the top. And the T2 weighted images are what the expert radiologists really lean on. So, what can you then do? If you're a surgeon and if you're in doubt about whether this is good or bad, you can cut through the specimen, but that has to be removed before. This is not inside the patient, obviously. And you can see differences. This is a fibroma, and this is a hemorrhagic sarcoma in the same patient. Over here, you can see a couple of sarcomas, and they are, they have more yellowish material, they have necrosis, they have bleeding, as compared to the benign fibroid. The endometrial stromal sarcoma is kind of interesting because when you do a hysteroscopy, you will often find little polyp-like extension like this one. And if you mistake that for a benign polyp and only excise the polyp, you won't get the diagnosis. The real sarcoma is here. And what you can see is that there's a lot of vessels inside. There's vessels with tumor also extending through the uterus. You can't see the limitation. Here's a normal myometrium on the other side. And you see when we cut through here, here is the endometrial stromal sarcoma. It's difficult to discriminate between an endometrial stromal sarcoma and a stroma nodulus, because you have to take the whole thing out in order to see invasion. Again, because these are indolent tumors and they have a low mitotic activity. Wouldn't it be nice if we just had a blood test that could do the whole thing? Unfortunately, with the CA-125, which is a good help with ovarian cancer, there's a big overlap between sarcomas and fibromas. Different groups are working with other kinds of blood tests, but I can't give you one that'll do the work right now. They have been working with stop fractions of LDH, neutrophils, granulocyte lymphocyte ratio, and a lot of other things. Maybe in the future, what Michael Thompson is working with could help us, I don't know. The primary treatment for sarcoma is radical surgery, preferably in a tertiary center. Unfortunately, because of the problems with diagnosis, a lot of sarcomas are operated on in minor hospitals because they thought it was a fibroid. What we do is, when we get the diagnosis beforehand, with leiomyosarcomas, we recommend hysterectomy and bilateral salpingo oophorectomy in all peri- and postmenopausal women, but we believe that oophorectomy can be avoided in the premenopausal women with a leiomyosarcoma, and I'll come back to that. With the endometrial stromal sarcoma, however, it is important to do both hysterectomy and bilateral salpingo-oophorectomy, even in the premenopausal women. Lymphadenectomy is not recommended unless clinically suspicious, and surgery for recurrent sarcomas should always be done in tertiary centers. Unfortunately, we don't have any good experience with chemo and radiotherapy, and it's not recommended in the adjuvant setting if you have radical surgery. Now, why not lymphadenectomy? As you can see, we find lymph node metastasis. This is a paper from 2016, in approximately 10% of the women. However, in a review of 5 studies on leiomyosarcomas and 11 studies on endometrial stromal sarcoma, there was no improved survival with lymphadenectomy. It's a meta-analysis of almost 5,000 women. Having said that, of course, if you see a lymph node like this one, it has to be removed. The background for why we don't recommend bilateral salpingo-oophorectomy in the premenopausal women with leiomyosarcoma is the study. Here you have the blue line is those who had oophorectomy, and the yellow line is those who did not have oophorectomy. And all those, there's no statistical significant difference. There's even a tendency for better survival without removing the ovaries. And this is the total group of both pre- and post-menopausals. The picture is a little bit more blurred with the endometrial stromal sarcoma. And why do we still recommend oophorectomy even in the premenopausal women with endometrial stromal sarcoma? And that has to do with these data, even though they are retrospectively. And that's 10 years recurrence-free survival. And with bilateral salpingo-oophorectomy, the 10-year recurrence-free survival was 74.2%. Without oophorectomy, it was 7.6%. So we don't dare not to recommend oophorectomy even in the young women. Then could we give hormone replacement therapy? And the answer with low-grade endometrial stromal sarcoma is no, we cannot. This is a study from Yale University of 22 consecutive patients, with of whom 17 were in stadium 1. Now, you have to know that the average survival in stage 1 in endometrial sarcoma is very high, and at least they don't die within the first 10 years. But here there was 3 stage 1 patients, 43 to 46 years, that all died after having got estrogen replacement therapy. And that brings me on to survival. This is the Norwegian study I mentioned before. It is 30 years of follow-up. And you see the green line is the endometrial stromal sarcoma, and their 5-year survival is between 75 and 80%. And when we talk about 10 years, it's still more than 60%. And coming back to what I said before about estrogen replacement, don't do it in endometrial stromal sarcoma. The blue line, that is leiomyosarcomas, and the 5-year survival is down a little more than 40%. That is again why we have to find the diagnosis prior to surgery, and that is a real challenge. The black line is the undifferentiated sarcomas, and here is the adenosarcomas. Our own data are more or less equivalent to this. The blue line here is the stromal sarcoma, low malignant, and we have a mean survival of 156 months, and we haven't reached the median survival even in a study that goes over 18 years now. So the survival with the endometrial stromal sarcoma low-grade is very. That is not the case with the green line, which is the leiomyosarcoma. We have a mean of 73 months and a median of 39 months. The undifferentiated sarcoma is even worse. And then that brings me on to the adenosarcoma, because what we find is that the adenosarcoma, which is the light green line, has the same survival as the leiomyosarcoma in the beginning, but then it levels off. And why is that? That is probably, I think, because adenosarcomas are different from adenosarcomas in the way that most of them have the low-grade endometrial stromal sarcoma as the mesenchymal element, and adenosarcomas, of course, have the epithelial part, which is benign, but some of them have sarcomatous elements of other sarcomas, and I think those are the ones that die first, and then it levels off when we've only those left that had clean endometrial stromal sarcomas as a mesenchymal element. It is not because we didn't find the adenosarcomas early enough, because we actually found 83% in stage 1. So coming on to this one stump, that is not something I'm going to talk about. That's stromal tumor or unknown malignant potential, and obviously they have a good survival. There's the leiomyosarcomas, the endometrial stromal sarcomas, the undifferentiated, and the adenosarcomas. So how do we follow them up? We recommend that women with high malignant sarcomas should be followed up with clinical examination, and we do CT scans of the thorax and abdomen every 3 to 4 months for 2 to 3 years. Then we do every half year up to 5 years, and then yearly if they survive that long. Those with low malignant sarcomas, and that's the endometrial stromal sarcoma, we follow them up with CT scans also of the thorax and abdomen every 4 to 6 months for 5 years, and then yearly for 10 or more years, because some of them actually have recurrence after more than 10 years. Again, I think that when we do the surgery for the endometrial stromal sarcoma, we include the parametria, and we include the vessels all the way to the internal iliac, and we discuss whether also to resect the ovarian vessels, because the endometrial stromal sarcoma often have extensions out in the vessels before they actually do distal metastasis. Sometimes, it's not for me, I'm sure. Sometimes we do adjuvant radiotherapy if we don't have clean margins, but mainly with the endometrial stromal sarcomas, we could recommend hormone therapy afterwards, and that is with progesterone or aromatase inhibitors. We believe that all sarcoma patients should be discussed in multidisciplinary team conferences to decide follow-up scheme, and it should be done in a tertiary center. With respect to estrogen replacement therapy, of course, when you hysterectomize a young woman and you take out the ovaries, they have terrible climacteric symptoms. And we still believe that estrogen therapy is contraindicated, but you can try out low-dose progesterone. And high-dose progesterone is even used to treat the endometrial stromal sarcomas. Since bilateral salpingo-oophorectomy is not routine surgery in premenopausal women with leiomyosarcomas, we believe that this can be used on the usual indications during the climacteric. And we recommend that the sarcoma center should always be contacted prior to institution of any kind of hormone replacement therapy. The challenge is, well, the real challenge is to find the needle in the haystack. We need to find the 30 patients with a sarcoma among the 500,000 women with fibroids. And that is really the needle in the haystack. Because to do the right and correct operation, you need to know the right histological diagnosis. I've shown you the imaging technologies. What about biopsy? If you ever consider doing isolation of a fibroid, we recommend that in addition to an MRI, you should have not one biopsy, but multiple biopsies, which can be achieved both by hysteroscopy and transabdominally, and we do both, and it's multiple biopsies, because there are false negative biopsies. And then finally, remember that low malignant sarcomas can recur after many years, even more than 10. And with these few words, I thank you for your attention.